Cardiac arrest is extraordinarily common. It's the most common cause of death in the United States. The impacts of it are devastating. So patients who are resuscitated initially from cardiac arrest and are admitted to the hospital have an extraordinarily high mortality, higher than almost any other medical condition that we treat patients for. We know that over time, slowly, post-arrest outcomes are improving, but they're still inadequate. So a majority of hospitalized patients still go on to die after their cardiac arrest. And so far, there's relatively little by way of evidence to guide us in how to improve these patient outcomes. There's been a variety of drugs and treatment strategies that have been tested, and so far the only individual intervention we have that improves these patient outcomes is targeted temperature management, which is now standard of care for most of these patients. We know after a variety of brain injuries, cardiac arrest, but also strokes and traumatic injuries, that therapeutic nihilism, or a sense of futility among providers, has a tremendous impact on these patient outcomes. One of the ways that it impacts patient outcomes is by actually withdrawing care based on this sense that providers may have that patients have no possibility of recovering or no possibility of a favorable outcome, that they may live but that they'll never wake back up. And we also know that for many patients this actually isn't the case. And both individually for myself and talking with colleagues, we've all experienced the situation where we see a patient who in our heart of hearts we truly don't believe will recover. We don't believe they'll wake up. And sometimes we even counsel families to that. And then the patient surprises us and wakes up and has a favorable outcome and recovers. So personally, that's very humbling, and it makes you appreciate the uncertainty in what we do and also the power we have to inadvertently and adversely affect these patient outcomes, and also begs the question of just how often this does happen and what the significance of it is, not anecdotally and personally, but at a national or even international level. The original primed trial was done by the Resuscitation Outcomes Consortium, and it was a multi-center trial performed across North America in the US and Canada at the Resuscitation Outcome Consortium sites. Patients had suffered an out-of-hospital cardiac arrest and were treated by emergency medical providers. They were randomized to two different types of treatment strategies: early versus late analysis of their heart rhythm, and a device designed to improve blood flow during CPR. And then were brought to the treating hospitals and received fairly standardized care thereafter, although up to the discretion of the treating teams. So the population then is general residents of North America and Canada. They had a high burden of cardiovascular disease overall, as you might expect, having suffered a cardiac arrest. And for our particular subgroup, they had to have pulses back and survive the hospitalization, because we were really focused on an intervention which takes place in the hospital. So this took out a group of the post-arrest patients who were either evaluated by EMS and the decision was made not to treat, for example, if there were no signs of life on EMS arrival. It also took out a group of patients who were treated by EMS but never regained pulses. The most recently published guidelines were by this body, the American Heart Association, and the 2015 guidelines came out just in the last couple weeks. There's also consensus guidelines from the European counterparts to the American Heart Association and from several critical care or neurocritical care societies, all of which have looked at essentially the same evidence and come to the same conclusions. So I would say no, but that's actually really speaks to the question of nihilism that we were interested in investigating. So some physicians, even today, despite all evidence to the contrary, evaluate patients who are comatose after cardiac arrest and believe that they all have a poor prognosis. The evidence would go against that. We know that in the first days after cardiac arrest, many patients who initially appear comatose will go on to wake up. And we know that even among those who stay comatose 2, 3, or 4 days after cardiac arrest, some will wake up later, days later, and ultimately have a favorable neurologic outcome. What we know from the existing studies is that early on, in the first days after cardiac arrest, there's no test result, there's no physical sign, there's no combination of these test results or other signs that preclude a favorable outcome. And so I think the short answer to your question is no, they didn't all have a poor prognosis, and we have no way of knowing right now which ones may recover and which ones may not. So our primary findings were twofold. One was that despite evidence-based guidelines that suggest that neurologic prognostication should be delayed at least 72 hours after a cardiac arrest, withdrawal based on the perceived neurologic prognosis in those 3 days was extremely common. The most common day overall for withdrawal based on neurologic prognosis was the very first day of hospitalization, before there are any signs which preclude a favorable outcome. Second, we found that the predicted outcomes for those patients who were exposed to withdrawal of life-sustaining therapy based on what we thought their neurologic prognosis was in those first 72 hours, in the absence of that withdrawal of care, their predicted outcomes based on our data would actually be a 25% survival and a 16% rate of functionally favorable outcomes, which means able to walk with assistance, able to go back home, awake, aware of your surroundings. So nationally, if you extrapolate those data out, that would be over 2,000 lives saved across America each year just by delaying the decision to withdraw care until accurate neurologic prognostication is possible, and almost 1,500 patients each year who could go home with functionally favorable outcomes. So I think the take-home message is that life-sustaining therapy is not right for every patient. There are some patients who never wanted ICU care based on pre-existing advance directives, other comorbidities. There are some patients whose families don't believe that we should provide that care. In the absence of those patient preferences and values, we need to be humble as providers and delay our decisions to withdraw based on what we think a neurologic prognosis is until accurate data are available, which the evidence would suggest is at least 72 hours after cardiac arrest, if not longer.